Hi, you're watching Nursinga. Today we're going to discuss pediatric cardiovascular disorders. The cardiovascular system is needed early in embryonic development to support the metabolic demands of the dividing cells. Therefore, the cardiovascular system is the first functioning body system of the fetus, developing between 3 and 8 weeks gestation, often before the person knows they are pregnant. Congenital heart defects develop in utero and can occur alone or as part of a syndrome. They're often related to genetic, maternal, and/or environmental factors. Acquired heart disease appears after birth, and it's caused by other defects or illnesses that the baby is exposed to. Let's review the differences in circulation in utero and post-delivery. The fetus does not need to filter waste, so the ductus venosus bypasses the liver. It diverts most of the blood from the placenta into the inferior vena cava. The fetus also does not need to oxygenate blood, so the foramen ovale shunts blood from the right side to the left side of the heart through the atrial septum, and the ductus arteriosus shunts blood from the pulmonary artery to the aorta. After delivery, a couple breaths, a little bit of time, usually all three of these close relatively quickly within hours to days. Let's begin our discussion with the congenital heart defects. Heart defects are sometimes described as cyanotic or acyanotic, but are more accurately classified based on hemodynamics. Atrial septal defects, ventricular septal defects, and a patent ductus arteriosus after birth increase pulmonary blood flow. Coarctation of the aorta restricts blood flow, and tetralogy of fallot decreases pulmonary flow. The atrial septal defect is an opening in the septum between the right and the left atria. Oxygenated blood is shunted from the left to the right side. The patient will have a soft heart murmur and is at risk for clots and stroke prior to closure. Small ASDs may spontaneously close on their own. Larger require closure either by surgery in a Dacron patch or through a cardiac cath. Low-dose aspirin is usually prescribed for 6 months following repair, and the prognosis is excellent. Ventricular septal defects have a greater force of flow because the opening in the septum between the right and left ventricles has much higher pressure on the left side. Oxygenated blood is shunted from the left to the right, and there is a loud, harsh murmur with a palpable thrill during systole on the anterior chest wall. Small VSDs may also spontaneously close. Larger require surgical repair, also a suture or patch. Prognosis is excellent, especially with early repair. In fetal circulation, the ductus arteriosus shunts blood from the pulmonary artery to the aorta, and this normally closes shortly after birth. Once the newborn starts breathing and the lungs are perfused, the aorta now has a higher pressure than the pulmonary artery. If the ductus arteriosus remains patent or open, oxygenated blood then is shunted back from the aorta to the pulmonary artery. This causes a significant increase in pulmonary blood flow and can lead to congestive heart failure. IV indomethacin, which is a non-steroidal anti-inflammatory, encourages closure of a PDA. There's also thoracoscopic closure, or using a cardiac catheterization procedure to insert a coil that basically cauterizes it shut. Coarctation of the aorta is when there is a narrowing or restricting of the aortic arch or the descending aorta. It's not a shunt, and so the patient is not cyanotic. Normally, blood pressure is about 10 to 15 millimeters of mercury higher in the legs than the arms. Children with coarctation of the aorta have restricted blood flow to the lower extremities, with decreased blood pressure in the legs and leg pain with activity because of impaired perfusion. This can lead to chronic hypertension, heart failure, congestive heart failure, and even infective endocarditis. We repair this using cardiac catheterization, a percutaneous balloon angioplasty with stents, or even surgical removal and reanastomosis of the two pieces of the aorta. Tetralogy of Fallot occurs when there's a combination, so this is kind of a syndrome, but there's a combination of 4 defects: pulmonary artery stenosis, right ventricular hypertrophy, dextroposition of the aorta, which means that the root of the aorta is shifted to the right, and ventral septal defect. So combined, this leads to problems with oxygenation and right to left shunting. So deoxygenated blood is shunted to the left side, which leads then to chronic hypoxia and cyanosis. And the cyanosis actually increases with age. You will find children with tetralogy of Fallot oftentimes will squat to change the pressure dynamics within the mediastinum and improve oxygenation. Clubbing of the fingers and toes is common from chronic hypoxia. And because the kidneys are not getting adequate flow and oxygen, they release erythropoietin that tells the bone marrow to make more red blood cells. And so our kids with tetralogy of Fallot, or adults, have polycythemia, which is lots of red blood cells from chronic hypoxia. So oftentimes, when they're not cyanotic, they appear kind of red or flushed. On X-ray, the heart appears kind of boot-shaped from the way that it's kind of misshapen. We also see very commonly feeding problems, failure to thrive. They don't hit normal milestones on the growth chart. Cerebral thrombosis, so a stroke from a blood clot from the polycythemia, is common, especially if they get dehydrated. So monitoring fluid balance is critical. Iron deficiency anemia from decreased appetite and the increased energy required to suck or eat. And frequent respiratory infections, especially if they have the congestive heart failure part. Bacterial endocarditis is also common. So the treatment for this is IV prostaglandins to maintain an open ductus arteriosus that will improve oxygenation until surgery is performed. And then surgery helps to dilate the pulmonary artery stenosis and patch the ventricular septal defect, kind of putting the aorta back where it needs to go as well. So when those kind of 3 things occur, then the pressure is relieved out of the right ventricle and it doesn't have to work so hard, and many of the side effects and symptoms actually will resolve. So there's kind of a new cardiac procedure that they've been doing recently that's been showing really good results. So one of the things that happens to our babies with tetralogy of Fallot is they have these paroxysmal hypercyanotic episodes, which are sometimes referred to as TET spells. And these usually occur primarily during the first 2 years of life, where the child experiences profound cyanosis, respiratory distress, weakness, and even syncope. Usually it's precipitated by either crying, defecating, or feeding, and it can last up to a few either minutes to hours, followed by lethargy and sleep, almost like the postictal phase of a seizure. The older child will squat, bringing their knees up towards their chest, and in an infant, you want to place the child in the knee-chest position, which you place their back against your chest and then bring their knees up towards their own chest, and that will put them kind of into a squatting position called knee-chest position and allow the changes in the pressure dynamics in the mediastinum to kind of fix the problem that they're having. Hypoplastic left heart syndrome is critical. These are usually diagnosed in utero by ultrasound, but it occurs when the left ventricle is non-functional. It's either undeveloped or completely absent. And in order to survive, the baby needs to have a patent foramen ovale and ideally a patent ductus arteriosus, both of those. Now, IV prostaglandin administration is given to keep both of those shunts open. So if I give an antiprostaglandin, if I give indomethacin, I can close those shunts. If I want to keep the shunts open, I give prostaglandins to keep them open. There's a 3-step cardiac surgery that can be used until transplant is available, but as soon as we recognize this on ultrasound in prenatal care, these babies are put on a transplant list. And as soon as possible, then they get a heart transplant. Usually when they're born, they're grayish blue color. The mucous membranes remain very dusky. They have chronic dyspnea, very weak pulses, and a profound heart murmur. Prognosis overall is poor, although survival is improving, especially with this 3-step cardiac surgery. After transplant, they do need anti-rejection medications, which puts them at a very high risk for infection. And the last congenital defect that I want to talk about is transposition of the great vessels. This occurs when the aorta and the pulmonary artery are reversed on the outside of the heart, so that the blood that circulates from the body goes directly back to the body, and the blood that is circulating from the lungs is just going left atrium, left ventricle, lungs, left atrium, left ventricle, lungs. So there's absolutely no circulating oxygenated blood unless you have a patent foramen ovale and a patent ductus arteriosus. So those two, again, are required in order to sustain life. So we would give IV prostaglandin E1 and immediate cardiac surgery in order to save this child's life. And they need to fix those two vessels and put them back where they belong. So care of the child who's receiving a cardiac catheterization for any of these defects, preoperatively they need to be NPO for 4 hours. Remember, with children, we don't like them to be NPO for long periods of time because they get dehydrated and they get hypoglycemic, and that's not good. So 4 hours is a good window, and that's the longest that you can go for an infant or a neonate. Postoperatively, the things that we worry about are blood clots and hemorrhage. So you want to check the vital signs and the puncture site where they went into the artery, usually femoral artery, and there'll be a pressure dressing on that for evidence of bleeding. So you're looking for hematoma, you're looking for tachycardia, you're looking for tachypnea, you're looking for hypotension, you're looking for a big hematoma or evidence of bleeding on the dressing itself. And then you're also looking for evidence of a thrombus or a clot that can occur just from irritation of the vessel itself. So you're going to do neurovascular checks, especially in the extremity where the catheter went in. So you're going to check color, sensation, mobility, temperature, and peripheral pulses, keeping in mind, the pain, pallor, paresthesias, poikilothermia, and pulselessness would be evidence of acute arterial occlusion that it can occur after cardiac catheterization. Providing emotional support for the child and the family is key. And then education for the child and the parents with a cardiac disorder includes things like health, hygiene, dental care, diet, and immunizations. Nutrition is really aimed at preventing anemia and promoting optimal growth and development. We want to avoid fatigue, so rest is really important. Prevent respiratory infections, and competitive sports are avoided in children with congenital heart disease, so help them focus on which activities and sports they can do. Avoid high altitudes or very cold environments because that impedes peripheral blood flow. The child who has open heart surgery usually has a chest tube afterwards. Just like with an adult, this system has to remain sealed in order to keep that lung reinflated. and the drainage system needs to be below the level of the tube or the chest in order to prevent backflow and infection of the blood or the fluid that's draining out. It is still recommended that you keep 2 padded Kelly clamps at the bedside or when you're transporting for emergency only. If something were to get cut or broken with the system, you would clamp the tube only in severe emergencies to prevent air from going back into the tube and recollapsing the lung. And then transplant care. So for the child who's had a heart transplant, they will end up in ICU. But once they get home, infection and rejection are the primary causes of death. And so we would be monitoring for signs and symptoms of infection or of rejection. So acquired heart disease, as I said, occurs after birth and usually is a complication of either congenital heart disease, respiratory disease, sepsis, or endocarditis, or prolonged hypertension, severe anemia, or other infections. So let's talk about hypertension and hyperlipidemia first. Hypertension in kids is more common than it used to be. And so it's really important to get an accurate blood pressure. Be sure to use the correct size blood pressure cuff when taking a child's blood pressure. So just like obesity, we're seeing it more often during childhood and adolescence. The definition of hypertension is when the blood pressure is greater than 95% of the normogram for the age and gender of that specific child. There's 2 types. There's primary or essential hypertension, where there's really no known cause, and usually this is related to things like obesity. And then there's secondary hypertension, which can be explained by a known disease, like a renal disorder, vascular disorder, endocrine disorder, or some sort of congenital anomaly. Heredity, obesity, stress, poor diet, sedentary lifestyle are contributing factors, especially to primary or essential hypertension. And it's definitely more prevalent in kids whose parents have high blood pressure. Treatment for kids is the same as for adults: diet and exercise, nutritional counseling, weight reduction, age-appropriate aerobic exercise, and then counsel adolescents specifically on the adverse effects of drugs, alcohol, tobacco, and focus the treatment on secondary hypertension on the underlying disease which causes the high blood pressure. Hyperlipidemia is also becoming more common in kids. If screening detects an elevated lipid level, begin education regarding diet and lifestyle changes. Reduce overall calorie intake, increase fiber, and increase regular exercise. Really promote lifelong healthy eating habits. It's important that we don't restrict fat in children who are under 2 because lipids are essential for normal brain and CNS development. So who do we screen? We screen kids who have a family history, parents who have a total cholesterol of greater than 240, or a family history of early cardiac death, so a relative who died under the age of 55 from a heart attack. Other risk factors include obesity, sedentary lifestyle, diabetes, tobacco use, and hypertension. So we definitely aren't screening enough kids, but the ones that we do screen, we want to treat as soon as we recognize that there's a risk. Heart failure then can be caused by hypertension, and certainly hyperlipidemia can contribute to that. So heart failure occurs when there's a decrease in cardiac output significant enough that the heart can no longer meet the metabolic needs of the body. And this means that we have inadequate perfusion to the cells. We're not getting enough oxygen, we're not getting enough glucose, we're not getting enough just like plasma and perfusion. And so therefore, we're not removing the waste products and we're not delivering the fresh nutrients. Congestive heart failure is when the vessels themselves become congested. They have fluid volume overload due to inadequate heart pumping. So the plasma and the cells kind of get backed up and flood the vessels in the space that lead up to the failed pump. So on the left side of the heart gets its blood flow from the lungs. So if the left side of the heart fails, it backs up into the lungs. So that's where we get the crackles and the, orthopnea and the difficulty breathing. The right side of the heart gets its blood flow from the body. So when the right side of the heart fails, it backs up into the whole body system. So we get the jugular vein distension and the puffy eyes, the puffy belly, we get splenomegaly, hepatomegaly, and even peripheral edema. The main cause of left-sided heart failure is usually hypertension or difficulty of the left side pumping out of the aortic valve or aorta. And the right-sided heart failure can occur from either left-sided heart failure or cor pulmonale or some sort of difficulty with flow through the pulmonary system. Early signs of heart failure are things like shortness of breath, tachycardia at rest, getting fatigued during feedings, sweating around the scalp and forehead, and sudden weight gain. And unfortunately, poor cardiac output leads to decreased renal perfusion, which then activates the RAS system and the sympathetic nervous system. That fight or flight response, which increases heart rate, respiratory rate, the workload of the heart, and makes them overall worse. Our goals of management for children with cardiac disease, and especially heart failure, are really focused on decreasing cardiac workload, improving gas exchange, adequate nutrition, and avoiding infection. Feelings should be addressed to decrease anxiety, and the patient and family should be supported and educated as appropriate. You want to adjust your care as needed to really help conserve the child's energy. Rest is critical. Organize the care so that the infant is not unnecessarily disturbed. Oxygen can be administered to relieve dyspnea or any hypoxia. Feedings are small and frequent with a high calorie formula, but don't use low sodium formulas because those really are not well tolerated and can cause big fluid shifts. You do want to use a bottle that has a nipple with a large opening so that they don't have to work hard to feed. Basically, they can just kind of close their mouth on it and it will drip in. You want to feed them early if they start crying. And you want to feed them late if they're sleeping so that they can rest. And if they're too tired to feed, just put an NG or an OG tube in there and feed for them so that they don't have to work at all. For the older child, you should really focus on a diet that's rich in iron, adequate fluids, and sometimes sodium is restricted. So what's important for those older kids is a sense of control and choices. So you want to allow them to make choices from the menu with guidance, of course, from the nurse. So every day look at the menu with them and help them pick out good food choices so that they can learn what to choose when they're not with you. Medications that are used for heart failure include digoxin, which is a cardiac glycoside. It's an inotrope. It is used to improve cardiac output. This is a critical drug that needs 2 nurses to check the dose prior to administration. As the nurse administering the dose, you have to check the apical pulse for 1 full minute. And if the apical pulse is less than 100 for a newborn or a smaller child, or less than 70 for an older child, you must hold the medication and notify the provider. It's important because there's not specific age guidelines of exactly where that 170 split, that the orders for digoxin come with very specific orders to hold the dose if less than 100 per se. You should also monitor for signs of toxicity. So it's important that you report tachycardia, any irregular heart rhythm, and then the GI stuff, nausea, vomiting, anorexia, or any sudden changes in condition, like a sudden change in heart rate or rhythm, because those are signs of toxicity. If the child vomits after you administer the dose of digoxin, do not repeat the dose, but notify the provider. Because the therapeutic range is so narrow, it would be easy to make them toxic if you refed it. ACE inhibitors are also used in pediatrics for hypertension. And just like with adults, you need to monitor for the common side effects of hypotension, especially orthostatic hypotension, a dry cough, renal dysfunction, and hyperkalemia. Diuretics are also used in children with heart failure. Lasix and Diuryl are common. They reduce edema. And then spironolactone can also be used. Remember that Lasix is potassium wasting, where spironolactone is not. As the nurse, you must monitor serum electrolyte levels for imbalances and teach parents about appropriate foods and potassium use. So if I was giving Lasix to a child, I would want them to understand, the parents or the child depending on the age, that foods like oranges, milk, bananas, potatoes, prunes, cantaloupe, mushrooms, avocado, salmon, those are all high in potassium. Versus if I was giving spironolactone, I would want them to avoid foods that are really high in potassium. And then fluid balance is critical as well. Children need to be weighed every single day if you're concerned about fluid balance. You need to keep a very accurate I&O, and that includes weighing the diapers. And then frequent position changes to prevent hypostatic pneumonia, especially in the child who is dehydrated or fluid volume deficient. Rheumatic fever is a systemic autoimmune collagen disease that destroys connective tissue, usually as a complication of untreated group A beta hemolytic strep or strep throat. And this is why, very specifically, that we give penicillin for strep throat, this and glomerulonephritis. Rheumatic fever involves the joints, heart, central nervous system, skin, and subcutaneous tissues. And while a lot of the signs and symptoms resolve, it causes permanent damage to the heart. It scars the mitral valve, and it causes damage to the myocardium, the actual heart muscle itself. We see this most commonly in kids between 5 and 15 years of age. A positive diagnosis requires the presence of either 2 major or 1 major and 2 minor criteria. Carditis is the most serious complication of rheumatic fever, and this, we call it rheumatic heart disease or rheumatic carditis. Again, it leads to mitral valve stenosis and the development of Aschoff bodies, and these are these little fibrous lesions in the heart muscle itself. Over time, the mitral valve can even prolapse and the patient can develop a very significant murmur, and it can lead to infective endocarditis. Migratory polyarthritis occurs for a few days here and there in the larger joints. They become inflamed, difficult to move, very painful, and it will move from joint to joint on and off for a few weeks and then disappear. Erythema marginatum is a red rash that usually occurs on the trunk and the abdomen, where it kind of spreads outward and the center of the lesions fade, leaving these red elevated edges. And then we have Sydenham's chorea, and this is starts off oftentimes with just like this clumsiness or fumbling, facial twitching, difficulty speaking, and then also involves limb movement. So chorea, like Huntington's chorea, are these involuntary movements. They're very purposeless, kind of jerky movements, and this usually resolves within a few weeks. But there are many physicians where if they see this chorea, they will diagnose rheumatic fever based just on Sydenham's chorea itself. And then subcutaneous nodules are just little nodules underneath the skin. Minor criteria then are things like fever, joint pain, history of rheumatic heart disease, a new first-degree AV block, so prolonged Peter-R interval on the EKG, an elevated erythrocyte sedimentation rate, or ESR, elevated white blood cell count, or leukocytosis, and a positive C-reactive protein. So the elevated ESR or erythrocyte sedimentation rate, leukocytosis, and a positive C-reactive protein or CRP are 3 signs of inflammation. Those are markers that we look at in the blood work that tell us that there's inflammation. And that's pretty critical when we monitor those to make sure, especially the ESR and the white blood cell count, to make sure that they're going back down to normal. So treatment is penicillin, typically for 10 days, bed rest, and we want periods of uninterrupted rest to allow the heart to rest and recover. If you decrease activity, you're going to decrease the myocardial oxygen demand and the stress that you're putting on the myocardium. And that needs to occur until that SED rate, the erythrocyte sedimentation rate, is back down to normal. You want to relieve pain and fever with anti-inflammatory and antipyretics. And then anti-inflammatory agents like steroids and non-steroidal anti-inflammatories are also used for not only severe cardiac symptoms, but also for the arthralgias and the joint involvement as well. You want to manage cardiac failure, heart failure. If it occurs, phenobarbital can be used for the chorea. And then pay special attention to the skin, the back, and oral hygiene. Children often receive monthly prophylaxis after a diagnosis, and before dental procedures, they oftentimes also will be treated with antibiotics to prevent spontaneous bacterial endocarditis. Prevention, so how do we not get this? Because it's believed that a certain percentage of the population is just genetically predisposed to this, and some people will have strep throat and have no risk of this at all. So prevention-wise is prompt treatment of strep throat. So group A beta hemolytic strep throat infections need to be treated with antibiotics, and that's kind of where we're at. And although we know only a small percentage of the population will develop rheumatic heart disease, it is a very significant complication of not treating strep throat. You need to stress the importance of completing all antibiotic therapy as prescribed so that they don't develop this as a side effect. And last but not least is Kawasaki disease. And this is the #1 cause of acquired cardiac disease in the United States. It doesn't occur very often, but the side effects are high. This is characterized by a high fever that lasts greater than 5 days, which does not respond to Tylenol or ibuprofen. And on exam, the conjunctiva of the eyes are bright red, as well as the mucous membranes, and the tongue, oftentimes referred to as a strawberry tongue. The lips become very dry, cracked, and fissured, sometimes even turning like a black color. The lymph nodes, especially of the neck, become incredibly enlarged. And then there's this kind of erythematous skin rash that covers the body. On the palms of the hands and the soles of the feet, they get very swollen, and then desquamation occurs. So the skin actually sloughs off or peels off almost in sheets. The child is very, very irritable, and they may develop signs of cardiac problems. Once this is diagnosed, early IV gamma globulin can prevent coronary artery damage, and aspirin therapy helps prevent the development of a thrombus. Warfarin is used if aneurysms are already detected. So most of our care is supportive, as well as a lot of teaching with the parents to delay immunizations, oftentimes for 9 months to a year after treatment is completed, so that they don't have any negative effects, and they can develop adequate antibodies to the immunizations. And then stress the importance of continuing aspirin or warfarin as ordered so that they don't develop a thrombus. So why would a child with Kawasaki's disease develop a thrombus? Because they develop aneurysms, and aneurysms allow blood to pool, which then can create clots. So Kawasaki disease causes inflammation of the vessels in the cardiovascular system, very specifically the coronary arteries, so the arteries of the heart, and the aorta. And this weakens the walls of the vessels. About 40% of these kids will develop an aneurysm, or this abnormal dilation in the wall of the blood vessel, if they're not adequately treated. And these can either rupture where they bleed, or it can cause a thrombus, a blood clot, to form, and then they can have a heart attack or a stroke. So these aneurysms can become life-threatening. Children with Kawasaki disease are oftentimes placed on long-term aspirin therapy and are closely followed with like a cardiac echocardiogram or an ultrasound or some sort of imaging to make sure that aneurysms do not develop after diagnosis or therapy. So to kind of recap, it's critical that you can recognize the common signs and symptoms associated with cardiac problems in children. And the things that most of these have in common that you would need to report immediately would be things like poor feeding, failure to thrive, fatigue during feeding or fatigue during activity, tachypnea, dyspnea, tachycardia or irregular pulse rates, cyanosis, pallor, and cyanosis is not enough oxygen, and pallor is poor perfusion, so both of those are a problem. Excessive perspiration, especially over the forehead. Visually observed pulsations of the neck veins, so you can see distended pulsating jugular veins. Clubbing of the fingers would be a chronic thing, but if an undiagnosed child, that would be a concern. And then additionally, one I want to mention is that bradycardia might be a sign of impending cardiac arrest in the child with hypoxia. So anytime you have a child who you're concerned about with any of these other signs and symptoms, and then you notice that they have become bradycardic, especially in the presence of hypoxia, you would need to notify somebody right away. That would be a true life-threatening emergency. So that is what I have for you on pediatric cardiac emergencies and disorders, and I just want to thank you again for watching.